First, like to thank all our speakers of the session, all great talks. We have time for maybe just a few questions from the audience. One was for Dr. Langer. If you need to resuspend the lateral canthus after placement of a large lateral orbital rim 3D implant, are there drill holes that need to be placed into the implant, and are these possible, or do you have to, how do you manage that?
I missed the first part of your question, but you're asking, are there drill holes in the implant?
Right, so if you have a large lateral orbital rim implant and you need to resuspend the lateral canthus, how do you do that?
That's a great question. That material, like the PEEK and the PEC, are very hard, so you probably would have to put a drill if you have a lateral wall implant. I mean, if you have to take off the whole lateral wall, that is a problem. You'll probably have to drill a hole into it and then resuspend it through the hole, I would suspect.
Okay. And then for Dr. Dafgard-Kopp, why would you advocate FNA biopsy for a dermoid cyst when there's a known risk of intense inflammation if the cyst ruptures? So it sounds like they're asking, would you still do a FNA biopsy for a dermoid cyst, even though there could be inflammation?
Sorry, even though it is an inflammation, or what? If I do, no, it's very seldom we do fine needle for dermal cysts.
So you would not recommend doing that?
That
Okay.
would it be if it's orbital, not the superficial ones.
Okay. And then for Dr. Vajafi, what would be your recommended material for the orbital floor repair? Kind of a broad question. What kind of implant would you like?
So I presently use porous polyethylene with titanium embedded. I like that implant. It allows for you to mold the implant to the correct shape. Remember, you want to have a nice upslope as the floor transitions along the medial wall there. The porous polyethylene has a smooth side, so it doesn't stick either. Certainly, just like Dr. Langer said, I do not print 3D implants for just an isolated blowout fracture. That's really an overkill and waste of money.
And what is the timing, this is for Dr. Schinder, what is the timing of the IV steroid compared to the IV antibiotic?
If I understand the question correctly, so the child comes in with the parent to the PDR. Once we have a diagnosis clinically and radiographically, they're admitted with antibiotics and steroids concurrently. And that's continued for 3 days worth of steroids, at which point they're discontinued. The antibiotics, when the child is clinically ready, get transitioned to PO, and then they're discharged on the PO. So they're given concurrently upon recognition and admission of the diagnosis, and then we gave the steroids for 3 days, and then they were terminated.
Okay, are there any other, yep. Go ahead, Veda.
Yes, Peter. Yes. Yes. That's a good question. Yes, the patient was radiated.
And so, because at our hospital, we so stay away from implants in a radiated. How many cases have you done where the big implant was not extruded after high-dose radiation?
That's a good question. You know, I've only been putting in 3D implants for about 7 years. So in cases like that gentleman was done like in the past year, so I can't really have a lot of follow-up to tell you that I know for sure it's not going to extrude. It might. I'd have to look back at the series. I think when I was doing this presentation, I think I've done 17 or 18, 3D printed implants where you're actually implanting. Oh, I don't do it that often. I mean, I agree with you. It usually is a problem. It depends on vascular, yourself, it depends how thick the tissue is over it and how vascular it is. So it's sort of an independent variable that's different from every patient. But would you normally, so typically in a case like that, you would just leave it alone?
Well, so far we have hundreds of patients.
Yeah, of course, I'm sure you do.
Thank you.
I was hoping you would have done so many so I can start.
No, yeah, I think one of the very important things, that some of the cases I've done alone, obviously the one I did with a neurosurgeon, I had a neurosurgeon there. That case with the maxillectomy, the ENT department had done a lot of work on that person, and so I had the facial plastic surgeon with me. And one of the reasons was it's very important for those implants not to be exposed posteriorly. So you can't really get into the sinus, because if it's exposed, then it probably will have a biofilm that eventually will expose. So it really helps to have that dissection plane so there's something behind it. So you really don't want to get into that plane. So they may help you out, with their dissection plane through the mouth or through the nose or whatever. So I think if you can get it covered on the front and the back, the anterior and posterior surface are both covered by tissue, I think you're safe, honestly, especially if you wait if you wait a while till the radiation effects have completed.
Okay, I think we're out of the time for the session, so thank you very much.